Hi, Dr. Leong.
Hi, Daryl.
Hi. Hi. So, thanks. Welcome to our conference. We're very glad you're here. Can you tell us what kind of doctor you are and where you practice?
Sure, I'm a cardiologist by profession. I work at McMaster University in Hamilton, in Canada, and I lead the Cardio-Oncology program here, which is a service dedicated to the cardiovascular health of folks who suffer from cancers or complications from cancer treatments.
So that's a very unusual field, or common, or what?
It's a pretty new field and one that's growing. So now in probably most university hospitals and large institutions in North America, you'd be able to find a cardio-oncology service. Probably, these services started to spring up in the last 5 or 10 years, but it's become a big thing and become more and more widespread just because we know that patients are living longer with cancer, with all the improvements in cancer therapeutics. And so we need to pay attention to the side effects of these therapies, and also to, I guess, issues more broadly around survivorship from cancer and what that means.
Yeah. And in your practice, do you see a number of prostate cancer patients?
I see a lot of prostate cancer patients. That's one of the areas of interest that I have. Obviously, with prostate cancer, there is some interest and a lot of research being done into cardiovascular health in folks, especially receiving hormonal therapy. And so that's really one area that I specialize in.
So advanced stage prostate cancer patients usually present to you with cardiovascular distress or actual difficulty leading to some sort of diagnosis. Is that fair?
Yeah, so a lot of folks with prostate cancer have either a cardiovascular disease, be it heart disease or a history of a stroke or conditions like that, or they've got risk factors for developing these conditions. And so they are one population we're interested in. And along with that, the hormonal therapy that many of your viewers would be familiar with can also increase the risk factors for cardiovascular disease by causing things like weight gain, changes in blood pressure and glucose levels. And so these are risk factors for developing heart disease and stroke in the future.
So we'll get to that in 3.5 to 5 minutes, or more or less. But I'm curious. I mean, prostate cancer typically, skews towards older males, older men. I mean, in our organization, we have a large program for guys diagnosed under the age of 50, and we have many guys in their 30s and 40s. But like it or not, it's fair to say 55 and on up. Prostate cancer world. The idea that there's do people come to your practice, to your work, and to the work of your colleagues because they're just older guys who, prostate cancer or not, just have cardiovascular issues?
Yeah, that's a great question. There's no doubt being an older male is linked with an increasing risk of developing cardiovascular health problems. So that, I'm certain, is part of it. There are also, I guess, some risk factors for prostate cancer that also happen to be risk factors for cardiovascular disease. So for instance, being overweight or obese is a risk factor perhaps for more aggressive prostate cancers, and it's also a risk factor for developing heart attacks, as an example. And so whether it's these common risk factors that are what cause both the cardiovascular disease and the prostate cancer is another possibility as well.
Yeah, and the guys that come to you, I mean, you're in Canada, but do you see are there disparities among races and perhaps cultural disparities as well?
Terrific question. I guess Canada having a sort of government insured healthcare system in all of the provinces is in a fortunate position. And I find that the disparities in healthcare is a little less than what you might find in some other settings. And so we, certainly in our experience, have a much more homogeneous, a more uniform patient population. A lot of our experience actually comes through a research study that I'm leading with one of my colleagues here, Dr. Jonathan Pinthas, who's a urologist. And we've studied about 2,700 Canadian men with prostate cancer. We find that of this, 90% or more are white males, and generally their level of healthcare, their level of education is pretty good, so that they're a fairly homogeneous population. What we're now trying to do is look overseas to other countries, the US, Australia, other countries around the world, to do the same sort of research there and understand if there are differences in patterns of patients with prostate cancer.
Yeah, and around cardiovascular stuff in the States, I mean, there's sort of like this sort of, I don't know, conventional wisdom, if you will, that people from lesser developed economic areas will present overweight, Black and white men, and they're just diabetes, cardiovascular stuff, hypertension, the whole gambit of people that probably sit in your waiting room. And, unfortunately, they also have prostate cancer, and they tend to fare worse than skinnier guys, for lack of a better term. Yeah. I mean, is that your experience?
Yeah, look, I think this is a really important topic and something we've actually spoken with colleagues in the US about, because I suspect, without having a great deal of firsthand expertise in it, that amongst, for instance, some minority communities, especially African Americans, that there may be such sort of disparities. There certainly are in other cardiovascular areas, and we know about them through our cardiology work. And so, I think this is a really important field that, I certainly need to learn more about. And we hope that research can provide us some more insights into the reasons behind these disparities and what can be done about them.
So let's now talk about men in advanced stage prostate cancer who typically will tell as a support group organization. Before COVID, we had 82 on-site support groups across the USA. Now everything's online, but that doesn't keep us from telling newly diagnosed guys to consider engaging a cardiologist, at least for a simple consult, whether you're experiencing anything or not. Androgen deprivation therapy impacts the body how?
So
relative to cardiac stuff. Sorry.
Yeah. Of course. Yeah, absolutely. Yeah. Look, testosterone is a key hormone for men. I think that goes without saying. We know that without it, men tend to put on weight. And with increasing weight, blood pressure tends to rise, and there's a tendency for sugar levels to rise as well, and a predisposition to getting diabetes. And sort of those three things, obesity, increasing sugar levels, increasing blood pressure, and more we're recognizing that loss of muscle strength and lean body mass is another side effect of androgen deprivation therapy, which is really important. We've shown in our research, and have a lot of other people, that these are risk factors for cardiovascular disease. And so it's not surprising that a lot of research suggests that there is a link between androgen deprivation therapy and a higher risk of developing cardiovascular problems. And so we're working on solutions and strategies to try to prevent cardiovascular problems from developing in folks who need androgen deprivation therapy. Because there's no doubt that, in men with advanced prostate cancer, ADT, prolongs survival, and it's an effective and long-standing treatment for prostate cancer. But our job in the cardio-oncology clinics is really to try to offset and mitigate some of the harmful side effects of ADT.
And it affects, let's say, healthy men who start ADT in the same way as previously overweight and diabetic or high sugar level men?
That's a really good question. Again, that's something that I think we'll have a much better answer to in our research, because we're currently following up these 2,700 Canadian men. We're starting to recruit, people with prostate cancer from other countries as well, and we're observing what happens over time and what effects androgen deprivation has on the physical measurements and body composition of people who get ADT. So the research that's been done so far tells us that, these metabolic types of changes do occur, but they don't tell us maybe who's more susceptible to it. And you may be right that it could be someone who's older or someone who starts off from a worse baseline is more susceptible to these kind of complications than someone who's younger and starting off from a fitter baseline. But I think that our research with the big study that we're doing is going to be able to give us more information about this in years to come.
Great. We'll look forward to that. So for today, what should these guys, what should our men do?
So we're also doing a trial, actually, because you mentioned that men with prostate cancer should, try to get an appointment to see a cardiologist and should pay attention to these things. We're actually doing a clinical trial to see if this should be kind of standard of care. So in our program, half of all men who agree to it are randomly allocated to actually see a cardiologist and have these risk factors taken care of, basically asking the question, should a cardiologist be part of the routine healthcare team of folks with prostate cancer? And so we're going to have the results of this sort of trial in the next few years. Until then, I agree that at least, raising these issues with your healthcare providers, be it family physician, be it an internist or your prostate cancer specialist, is a good idea. There are a wealth of information, especially from reputable organizations like the American Heart Association, on what should be done about things like blood pressure and diabetes and high cholesterol. And these are, we think, important guidelines that everyone in the public, men included with prostate cancer, should pay attention to.
So for the guy, oh, by the way, so in your trial, I mean, the control group, they're not seeing an actor pretending to be a cardiologist, right?
No, so in Canada, at least, and in many settings, the current standard of care is that if you have prostate cancer, you'll see your oncologist or your urologist and your family physician. There's no routine involvement of a cardiologist unless you have developed cardiovascular problems or have symptoms that are concerning. So we're trying to take that model a step further to say, look, should this be routine? Should a cardiologist be involved in every patient with prostate cancer?
Yeah. And, we're a bunch of psychologists and social workers at MailCare. I'm a social worker. I mean, A, we don't have an MD after our name. B, we don't know what the hell we're talking about. But, from just a sort of common sense point of view, prostate cancer is a problem when you're diagnosed with it. But there are other parts of the body that are also prone to problems as we get older. If we could use the diagnosis of prostate cancer as a kick in the ass to get guys to be vigilant about the rest of their body, which is to say, go see a cardiologist, if you can afford it, of course, then it's sort of like a why not kind of proposition. And if it uncovers something particularly acute, a blockage or something, then cheers for everybody, we saved a life, and if not, then as you say, they have a baseline and something to, sort of understand the progression of their body's journey through androgen deprivation therapy from day 1 through day 365 and onward. What, for the guy who is reluctant to go to a cardiologist, who's seen enough doctors, particularly advanced stage, most guys have seen 3 or 4 doctors by then, and everyone else, in between. What is the tangible warning signs? What are the tangible warning signs that they should, because something around their androgen deprivation therapy may impact their heart, and their heart may kill them before their prostate cancer would?
Yeah, I think to unpackage your last comment, which is really an important one, there are 2 issues. One, as you say, is there's definitely a rate of burnout and fatigue. As you say, the frequent appointments with physicians, even to have androgen deprivation administered every few months, it definitely, from the patients that I take care of, takes its toll, and is time consuming, not to mention costly as well. And so that can't be underestimated. And there are definitely people who, after going through that, really don't want to have to spend more of their time, effort, and possibly money in addressing other issues. And so the point that I would make in response to that is a lot of what we do in preventive cardiology is an upfront investment for a downstream gain. I tell a lot of my patients to think of it as putting money away, saving money for your retirement. The investment you make now, we hope, will pay dividends through better health in the future. And you may not actually know that you're benefiting from putting the money away now, from investing in your health now, because as the years roll by, if you don't have a heart attack and you don't have a stroke, you never think, geez, I really, was the right decision to invest all that time and effort in looking after my cardiovascular health. But I can tell you, for the people who have a disabling heart attack or a stroke or even die from it, that opportunity is kind of too late. And so, as you say, the diagnosis may represent, if you like, a bit of a wake-up call to pay attention to some of these other things. Now, I think the second point you made was, what are the warning signs that people should look out for? There are really two things that would concern me. One is the development of risk factors. And if you're on hormonal therapy, even if you don't see a doctor, you would feel fatigue. You may notice loss of muscle strength, harder going upstairs, for instance, because of a loss of strength in the legs. You may find yourself getting short-winded, short of breath easily. Those sorts of things, tell us that the hormonal therapy is having an effect on the body. Nowadays, there are lots of blood pressure machines that are available outside clinics, be it at drugstores. You can purchase these things off the shelf or from online retailers, and you can even check your blood pressure yourself, and you may find that that is going up as well. And once it goes to more than, let's say, 140 systolic, the top number, that's when we would be concerned you have hypertension. And that's something which is the strongest risk factor for developing a stroke and for other cardiovascular problems, not to mention things like dementia as well. So there are a lot of signs that you can detect even without seeing a physician that may cause you to be concerned. And the final level of concerning symptoms would really be the symptoms that I would worry about being cardiac in nature, like chest pain, especially on exertion, unexpected shortness of breath. Those sorts of things would really make me say to you that you need to be seeing a physician to get it evaluated further.
Yeah, a lot of people, including me, didn't plan on pulling this out, but have oximeters because of COVID and such. I'm glad to be a survivor, but I still sort of monitor my oxygen level. But it has a pulse meter too. It's checking my pulse. Some guys are concerned about, including me, every now and then I notice it's popping up well over 100 sitting here at my desk. Are there concerns around the rate of pulse for guys with androgen deprivation therapy?
Yeah, there's two things I think to be worried about. The first is if your pulse is a normal, regular rhythm and it's just fast. And there's been a lot of research to show that the faster your resting heart rate, when it is in a normal, regular rhythm, that is still a marker of less fitness, if you like, and is associated with worse outcomes in terms of heart disease and overall outcomes. So in general, the faster your pulse rate is when you're at rest, probably the more unfit you are. It's probably a measure of that. But probably the more important thing is when you actually have an abnormal heart rhythm. And the most common one that occurs in older people that we are worried about is atrial fibrillation. So if your pulse rate is irregular, or if it's really quite fast, like over 120 beats a minute at rest, these are things which should really prompt you to get that checked out in case it is atrial fibrillation, because that is an important risk factor for stroke.
What do you think of the, I think it's called Cardio-B or whatever, the at-home kind of EKG, devices, also like the glucose things you could put on your arm? What do you think of those things?
Look, I think they're really the future, and in some cases even the present. COVID has made us all change the way we work, and it's accelerated the acceptance of a lot of these at-home wearables and monitors. And I really feel that telehealth and these sorts of devices are going to be how we conduct a lot of healthcare moving forward, and COVID's going to accelerate that. The question is, what vendors, what machines you can trust. And really, we have to put our faith in our regulatory agencies that, if you can buy one of these devices off the shelf, that it's been through the necessary checks and approval processes so that it's giving us some reliable information.
Before we say goodbye for today's presentation, just slightly off topic. I mean, you're a cardio-oncologist. What's your experience with the metastases to the heart from prostate cancer?
Fortunately, low. It does not tend to go to the heart directly, which is a good thing because many other cancers do. As most of your viewers would know, it most commonly goes to the bones. And so that the heart metastasis is not something in prostate cancer that we see very often at all. In fact, I can't recall myself ever having seen a case. So that's a good thing.
Very good. Dr. Leong, thank you for taking good care of your patients, for working in a field that will certainly be important from yesterday on forward. And welcome to our conference.
Thanks very much for having me, Daryl. It's a pleasure.